Hello, everybody, and welcome to today's community conversation. This is our conversation on reducing suicide risk among veterans, the VA Risk ID strategy. And we will be getting started in just a moment or two. It looks like we still have some people joining the webinar. So I just want to wait another minute or two to see that everybody can get connected, and then we'll begin. You're welcome to have your cameras on or off if you'd like, whatever you're comfortable with. We do ask that you just make sure that you are muted during the presentation so that background noise does not disturb the presentation. You should have the opportunity today, if you'd like to ask questions of our presenter, to come online and speak as well. But if it's the case, we will ask you to unmute when we're ready to take those questions. So we'll just give it another minute or so, and then we'll get started.
Why can't I hear anything?
Okay, why don't we get underway? Thank you again for joining us today for our community conversation, reducing suicide risk among veterans, the VA Risk ID strategy. We're very pleased today to have with us Bradley Jacobs, who is the Suicide Prevention Coordinator for the VA New Jersey healthcare system. And Bradley will be sharing with us today some information about the tool that the VA has developed. And I also have a version of that tool that you will all be able to access. We've uploaded it to our website, and we'll be sharing a link to that in the chat when appropriate, and also sharing that with you via email at the end of the webinar. So thank you again for joining us. My name is Jeff Feldman. I'm the Director of Advocacy and Communications here at NASW New Jersey, and I'll be moderating today's call. Just to remind you all that this is a public forum, so we have a couple of housekeeping rules. We ask that you are please respectful of the presenter and your fellow attendees, and that, as I mentioned, you keep yourself on mute during the presentation to avoid disturbance. We also ask that you remember that as this is a public forum and we are recording this presentation as well as live streaming it on Facebook, we ask that you please remember that the chat screen is public as well, and that you avoid from posting any inappropriate comments, vulgarities, promotional materials in the chat field. So we'd greatly appreciate if you could avoid doing that. And otherwise, with that said, if you have questions for Bradley, as I mentioned, you'll have a chance to come online and ask those directly to him. You can also enter your questions in the chat, and we'll read them to Bradley when we break for Q&A as well. So with that, I'm very happy to turn things over to Bradley. Welcome, Brad. Thanks for joining us today.
Thank you, Jeff. Thank you so much for having me. Hi, everyone. It's really happy to be here and talk to you today about suicide prevention, and in particular, talk a little bit about some of the strategies the VA has been promoting and some of the initiatives we're working on, and specifically to focus a bit on a suicide risk assessment instrument developed at the VA. I'm just going to go ahead and share my screen and then share my slides. Okay. Let me get that started. Okay. Hoping you can all see that. So as Jeff mentioned, I'm a suicide prevention coordinator at the VA here in New Jersey, and I just want to take a moment to mention that I came to this position and working in suicide prevention largely because of my own personal and professional experiences with suicide. And as a clinical social worker, you know, I had for many years, having worked with people who died by suicide, and working with clients who attempted suicide, I'd always felt sort of under-trained, under-resourced, and not sure always of what the best approach and strategies were. And so when the opportunity to come work in the VA system addressing suicide prevention, knowing that it's a large integrated healthcare system, I really jumped at that opportunity. So just to briefly mention, there are 5 of us who work in suicide prevention for VA New Jersey. We're a small team. Our role, though, is dedicated exclusively to suicide prevention within the VA care system. A little bit about what we do is that we work with VA clinicians and staff to identify any veterans who could be at high risk for suicide. We then provide case management support and monitor their care. But we also work in tandem to help our system implement some suicide prevention directives. We do partnerships out in the community, which led to this opportunity to speak with you today. And certainly I can answer more questions about the ins and outs of how our suicide prevention team is built within the VA. As with any discussion that's talking about suicide, I think it's important to just say a lot of us have our own personal experiences with suicide. Talking about it can be really difficult. So everyone should know the Veterans Crisis Line number, which is the same number as the National Suicide Prevention Lifeline. It's the 1-800-273-8255 for military service members and veterans. They can press 1 and speak to a trained responder. And I think all of us should really know this number by heart or have it accessible as a resource for those we work with, but for ourselves and our own friends and family who may benefit from the crisis lines. So I'm just going to begin by jumping in at kind of a high level. I know I'm going to speak specifically about one aspect of the VA's strategy on suicide prevention, but it's important to kind of get a big overview. I don't want to spend a lot of time on the data, but what we know is that, in 2019, there were over 45,000 US adults who died by suicide. Over 6,000 of those were veterans. Some specific information that we do know is that older veterans account for the highest number of veteran suicide deaths, but younger veterans, particularly those 18 to 34, have the highest rate of suicide. So as a whole, the suicide rate for veterans is about 1.5 times that of the non-veteran adult population. But the younger veterans we're particularly concerned about in terms of their high rate of suicide. I think what's important to point out from the most recent national data on suicide is that for the first time since 2001, the total number of suicide deaths and the rate of suicide declined a little bit for both the non-veteran and veteran adult population. So a little bit of what we call an anchor of hope there. Yeah. When we talk about veterans and suicide, it's, when we talk about suicide at all, part of the conversation has to be about lethal means, how people attempt suicide or how people die by suicide. And when we have that conversation about veterans, we need to talk about the use of guns or firearms. Veterans use firearms more than non-veterans do in suicide attempts. So almost 70% of suicide deaths involved a firearm in 2019. The use of firearms has been also increasing over time for both male and female veterans. So it is not just male veterans using guns, female veterans do. I think when we talk about, when we raise the issue of guns and veterans and lethal means restriction, we are not talking about taking guns away from veterans. I think it's important to acknowledge that. What we are talking about is having conversations around how to keep guns secured, how to make sure it's difficult for someone to use them during a suicidal crisis. We know that suicidal crises tend to be brief, pretty acute. And so if it's hard for someone to use any type of lethal mean, the longer we can stretch out that time, the greater chances the will to live will kick back in and that person will get access to help. So when we talk about guns, we want to talk about storing them unloaded, locked with some sort of cable lock or in a gun safe. Is the key given to somebody else, not in the same place, the ammunition stored separately, just ways of slowing down the ability for someone to pick up that gun and use it in an impulsive crisis. Another thing that's important and kind of high level to talk about here is that there are approximately 20 million veterans in the US. That's less than 10% of the population. The VA, the Veterans Healthcare Administration, serves only about 30% of those veterans. So we're a huge healthcare system serving 6 million veterans a year, but that is still only 30% of the veteran population in the United States. So that's important because, for those of you who work in settings that are not within the VA healthcare system, or if you're a social worker who sees veterans that are not, there's a good chance they're not connected to the VA system, which is fine, but we need to communicate with you about how best to serve those veterans. And it's important for you to understand that there are lots of reasons why someone may not be utilizing VHA services. The other aspect of it is that's important. One of the things the VA has that's unique is that it is the largest integrated healthcare system in this country. A veteran getting treatment in New Jersey, we use the same medical record as a veteran getting treatment in Alaska. So if I'm working with someone who decides to move to Alaska or wants to go to Alaska for a period of time, I can communicate there. We have access to that record. It also creates a unique opportunity when it comes to looking at public health strategies, particularly around suicide prevention. We have a pool of data that can be really used to inform both research and practice and strategies at reducing suicide risk. All right, so in 2018, the VA created a 10-year strategy report. And I'm not going to go through the whole strategy. As I mentioned, I'm going to focus on that one you see there, which is the Enhanced Risk ID strategy. This is really a focus on identifying, monitoring, and intervening. But some things that are important to point out, right? Every VA has staff like me, suicide prevention coordinators or case managers whose sole job is working within suicide prevention. There are over 400 suicide prevention coordinators or case managers within the VA system of care. Big emphasis over the next year or two around safety planning and lethal means restriction. We're really getting focused now. The VA is sort of ramping up on enhancing access and creating evidence-based practices specific to suicide. So when we have someone at risk, can we get them access to the right evidence-based care? And then again, the sort of reach to community partners. Two of our team members are new positions at the VA. My colleague, Martha Rodriguez, who connected me to Jeff and Helen and NASW, is a community engagement and partnership coordinator. Her sole job is to branch outside the VA and connect with community organizations and people who could be working with those veterans not in the VA system of care. Suicide prevention is the VA's top clinical priority, and they believe that includes veterans who do not utilize VA healthcare. So we want to reduce suicide risk for all veterans. Okay, I'm about to dive right into focusing in on what I mean when we talk about risk ID, but I want to just give a moment to pause and see if there are any questions.
If you have a question for Bradley right now, you can raise your virtual hand in Zoom and we can call on you to speak. While we're waiting to see if anybody has questions right now, I did have a couple of quick follow-ups from what you've mentioned so far, Bradley. specifically with relation to reaching out to community partners. You'd noted on your slide that outreach to community partners was something that you were working on, and that Martha in your office was charged with that. For people here that may want to connect with the VA, that may want to bring VA resources into their agencies or clinical practices, how can they go about doing that?
You can give me a call or Martha a call. I have a slide on the end of this presentation that has our contact information. My email address is really easy. It's bradley.jacobs@va.gov. It's a great way to reach me. So you could always just shoot me an email that way. Martha, I think, actually has a number in her name, so I'm not going to remember it off the top of my head, but you'll see our names and contact information also shared. I know you uploaded those documents, so we're in there.
Great. Thanks so much, Bradley. Doesn't look like we have any other questions, so
okay.
Proceed.
All right, so risk ID. So the VA decided, so they'd used screenings and assessment tools to identify veterans at risk for years. But in 2018, they really decided they wanted to standardize that process and make sure that, every VA was implementing these strategies up to that standard. We also, know that suicide is actually a rare event. So how do you identify those people of those 6 million veterans? How are you going to find those who could be at risk? And also they took the mantra that suicide prevention is everyone's business really to heart. So most people who die by suicide were not actually last seen by a mental health provider. They were seen in primary care or in some other medical setting. So it's clear that if we're going to screen people for suicide risk or try to identify someone in a healthcare system, we have to look outside of mental health, behavioral healthcare settings, and encourage and have other healthcare providers involved in suicide prevention. So the VA has done that. So we've taken the Columbia Suicide Severity Rating Scale, and now every veteran has to be screened annually using that scale. When it is due to be done, so our record will tell us Bradley Jacobs at his appointment today needs to have his SRS screening done. If I have an eye appointment and my ophthalmologist is seeing me today and it's due, the ophthalmologist is going to do that Columbia screening. So we really broadened out like who does these screenings, who uses these instruments. Then if it's positive, right, if it indicates there's some presence of risk for suicide, that ophthalmologist is going to reach out to a licensed mental health provider to do a more comprehensive suicide risk evaluation, or what we call the CSRE. We like to put acronyms on everything at the VA, so we abbreviate and put everything into an acronym. I'm trying not to do that today, but I may default to doing that. So CSRE is just that. It's a more comprehensive suicide risk evaluation. That's the tool I'm going to spend a little bit more time talking on. And then for those who have some level of risk, can we incorporate and increase the amount of safety planning we're doing, right? Build suicide prevention safety plans. We use the Stanley Brown safety plan template, slightly modified for the VA. And again, with a heavy emphasis on lethal means restriction and talking about guns, because we're dealing with veterans, many of whom have weapons, have guns, and have access to them and know how to use them. A couple other things just to mention. I have the word there, predictive analytics. One of the strategies that the VA has incorporated around identifying veterans, which I don't have time to talk about today, we call ReachVet. It is a predictive analytics program. So they've created an algorithm that scans our medical record. And every month I get a report of veterans that have been identified through that algorithm who are showing some type of risk factor that could increase the risk for an adverse outcome or suicide. So they just give me that list of those who score in the top 0.1% in New Jersey in the VA system. And I work with providers to say, hey, let's look at what is happening with that veteran. And do we need to change their care? Let's outreach them and make sure they're okay. So they've looked at a lot of different ways of sort of identifying veterans throughout our healthcare system. Now turning to that CSRE, or that suicide risk evaluation. Our colleagues, the VA has what's called the Rocky Mountain MyRIC, and I'm going to have links for you to the Rocky Mountain MyRIC. Their website is a great resource. Most of the tools and some of the references here that I am talking about are available to you there. And they were the experts who sort of created this risk ID process and created this therapeutic risk management approach to suicide risk assessment. So what does that really mean? So knowing that there's no real standard of care around predicting suicide, it's really hard for us to do that. So we don't really have a standard of care for that, but we do have a standard of care for conducting a thorough risk assessment. And really therapeutic risk management refers to ensuring that the role and the competence of a clinician is aligned with some of the legal concerns surrounding suicide risk in practice. So there's really sort of 3 tiers to this approach. It's including objective measures in risk assessment, looking at acute and chronic risk stratification, right? So how at risk is the veteran, both in terms of chronic and acute, and then utilizing safety planning, right? Sort of how do you mitigate that risk that you have identified? The other thing that was key in their building of this instrument and in how we're being trained to assess is that so the Columbia, if you're familiar with it, is a screening instrument that's very structured. It's scripted. You have to read the questions in a certain way and in a certain order. Our CSRE, our evaluation tool, is not scripted intentionally. And while it sort of delineates key areas we need to make sure we cover, so it's structured in that sense, it doesn't tell me in what order to do them. It's relying on my clinical expertise and my clinical judgment to sort of take those key areas, and through my collaboration and my therapeutic alliance with the veteran, thoroughly do this assessment. So it's really trying to incorporate both the experience and clinical expertise of a clinician with standardization and structured practice. So before I give you a real glimpse of what the tool looks like, I want to give you a couple of case studies. Caveat on this: case study 1 is a veteran I'm familiar with. Case study 2 is from our Rocky Mountain MyRIC folks, so I don't know that veteran very well. But just to give you a sense of how this might work in practice. So case study 1, 30-year-old male veteran, served in the US Army 2011 to 2015. He's had 2 prior suicide attempts. One was he put a gun to his head, but was taken away, and guns have since been removed from the home. He did attempt to cut his wrists at one point about a year ago. His father stopped him. He's been unemployed for about 3 years. Currently, he's living with his girlfriend, who is very supportive, very involved in his care. He's diagnosed with PTSD and having active symptoms, right? He's having flashbacks, night sweats. He doesn't sleep very well. He reports some marijuana use. Today, he presents to his therapist saying, "I can't take it anymore. It's been 6 years and nothing helps." For context, he's referencing the death of his wife that he blames himself for. He acknowledges having access to medication, an antibiotic that he plans to use to overdose on. And he's also having homicidal thoughts to the commanding officers who he blames for preventing him from being there when his wife was dying. Okay, case study 2, 29-year-old female. She has a significant history of suicide attempts and chronic suicidal ideation, but right now is saying she's not suicidal and mood is stable. She's had numerous psychiatric admissions. Her family has a history of suicide. She does own a gun. She has been homeless in the past, but right now housing is stable. She has been in sobriety from alcohol dependence for about 6 months, and she is diagnosed with borderline personality disorder. Okay, so keep those two scenarios in your mind. This is pretty much the structure of our comprehensive suicide risk evaluation. One section is around exploring thoughts of suicide, both current and past, any recent suicidal behaviors. That includes not just attempts, but it could be things someone is doing to prepare, right? Maybe looking or scoping out places to jump from, could be collecting medications, could be buying a gun or cleaning their gun, writing suicide notes. Exploring some of the history of attempts and those behaviors and really kind of discerning what's the most recent, what's the most lethal attempt if they've made one. Looking for warning signs. What are warning signs that are present? Exploring with the veteran what those have looked like in the past. And looking for existing risk factors. And also really importantly, what are protective factors? What are the reasons the veteran is able to give for wanting to live? What keeps them going? Then there's a section on sort of what is our assessment of their risk? What is our clinical impression? And looking at both acute and chronic. And then finally, we give a disposition, right? What are some of the strategies, considering all those things that we've discussed with the veteran, that we want to put in place? What's the appropriate level of care? Okay, so just very briefly, and I don't want to take a lot of time on this because I know many of you are familiar with these. These are some of the warning signs. It's not an exhaustive list, but this is some of the warning signs we look for. Is the person talking about suicide? Are they saying anything, doing anything that shows signs of hopelessness? Feeling like there's no reason to go on? Is there increased rage or anger, drug or alcohol use? Do they feel disconnected, no sense of purpose, or do they feel like a burden to others, right? So these are some of the warning signs. When we look at risk factors, right, we look at prior history of suicide attempt. Is there a family history? Does the person have any, mental health, pre-existing mental health, substance use issues? What is their access to lethal means? Do they have a history of impulsive behavior? And how are they employed? Do they what's their financial situation? And then when we talk about veterans, there might be some additional risk factors we want to explore with them. What was their deployment history? What was their time in service like? Did they experience any injuries while they were in service? What sort of exposures to extreme trauma or stress did they experience, and how is that affecting them today? Okay, and then finally, those protective factors we talked about, right? These can be internal things that we look for. Does the veteran have good coping skills? Do they have connection to a spiritual community? Do they have strong religious beliefs? Do they have a sense of purpose or connection to something bigger than themselves? What are some of the external protective factors, right? What are their relationships like? Do they have a strong primary relationship, somebody they trust? Do they have a service dog? That's not in the case study of case study number 1, but that veteran has a service dog that he loves and connects with very strongly. And so we really want to explore what these protective factors could be, and asking very directly, like what in your life keeps you from killing yourself? What are some of the things that help motivate you to live? So taking all of that together, right? Exploring ideation, what is their intent to act on those suicidal thoughts? We're going to look at sort of when did these thoughts occur? How severe are they? Again, sort of exploring preparatory behavior, looking at those risk factors and protective factors. We're going to pull all that together and consider what are the, how do you think about their level of risk? And really beyond just a number on a scale, right? Like we're not looking at, are they a 10 for risk or a 1? But we're thinking about low, intermediate, or high. And like, is that now, or is that sometime in the future, or is it past risk? So when we talk about risk stratification in this model, we want to think about severity and temporality. So how severe is it? Is it low, intermediate, or high? Is it acute? By acute, we mean within minutes, days, hours, or is it chronic, right? This is something that's been ongoing for the veteran for a long time, months, years, and how do these intersect? Okay, so back to case study 1 and case study 2. Just a quick review. 30-year-old male, left the Army in 2015. He's had 2 prior attempts, currently unemployed, has a supportive girlfriend, experiencing severe PTSD symptoms, possibly using marijuana, speaking in a way that indicates a sense of hopelessness, and having thoughts of suicide and a plan to act on those thoughts, and having homicidal thoughts. So I'm not going to ask you to necessarily jump out and answer this question, but just think for a minute, what is your impression, right? Is it acute? In terms of acute risk, would you say this person is low, intermediate, or high? So I would assess them to be at high risk at this point in time. And then in terms of chronic risk, what is it that we know? What factors indicate, is this a chronic issue for this veteran? And I would say he's both acute high risk and chronic high risk. Case study number 2, 29-year-old female, 18 prior suicide attempts, and history of chronic suicidal ideation, but is reporting she's in a stable mood right now, not experiencing SI, stable housing, has maintained sobriety for 6 months, owns a gun. So when we talk about acute risk, right, what would our impression be? So for her, we're going to think of her acute risk as being low. Her chronic risk, however, is also high, right? She's got a significant history of suicide attempts, chronic, thoughts of suicide. So what does that all mean? You've got someone high acute risk versus high chronic risk. What strategies are best for those individuals at this time? And that's really what therapeutic risk management is focused on. Are your interventions really targeted to the specific risk factors and in terms of the stratification? So the interventions should be consistent with the risk levels determined. And we want to consider relevant modifiable risk factors. So what's modifiable in case study number 1, right? He's talking about he has pills in his hand. That is something we might be able to do something about, right? How do we get the pills away from him? How do we get the medication away? Having active PTSD symptoms, are we treating those? We can modify those things. What's not modifiable is his age, right? He's a young veteran. He's in that high risk cohort of the 18 to 35-year-olds. That's not going to change, except over time. So some strategies might be, we could talk about hospitalization if it's needed. We could talk about lethal means counseling. I didn't mention this before, but I think it's important to state. When we're thinking about our intervention, part of what is helpful in this tool from a clinician perspective is going through the structure and considering all these different components will help me not overreact, right? So veteran case study number 2, if I'm meeting her for the first time, she's telling me things that might be alarming, but her acute risk is not high. I'm not going to, based on what I've looked at, make a move to have her hospitalized. Case study number 1, however, different scenario, right? There's high acute risk going on. Does this person need to come to the hospital or not? So I want to think about those things. This is a tool meant to sort of help us clarify those decisions and support the decisions that we make. Okay, you have some screenshots of what this tool looks like in our record. So I just want to read to you from the one from the veteran who I was talking about. It's up on top, right? So risk mitigation plan, the provider is going to reach out to the suicide prevention coordinator if I'm not already involved, right? Let them know, hey, I might want you guys to follow this veteran. We're going to review and update or complete a safety plan. We're going to increase frequency of suicide risk screening. So I'm the veteran's treating therapist or psychiatrist. I might then say, I'm going to schedule an appointment for you in a couple of weeks. Or if you come out of the hospital, I want to make sure I work with the treatment team and follow up with you shortly thereafter. I should say these risk strategies are from an assessment done a couple of months after this crisis period. So he's now out of the hospital and the psychiatrist is evaluating the veteran and saying, okay, you're at intermediate acute risk. You don't need to go back in the hospital, but I'm going to put some things in place to sort of support you back out in the community. So how do you keep all this in mind? Another great resource for you at the Rocky Mountain MyRIC is the stratification table they created. It breaks down looking at acute risk, both low, intermediate, and high. What are some of the features of it, and what steps might you consider to take? And it breaks that down for chronic as well. And I think it's probably safe to say that when we look at this, acute high risk can often be pretty obvious, right? So that case study shows somebody who is really experiencing a crisis. They're at high acute risk. Our intervention is going to, want to be sort of commensurate with that, right? We probably need to have an intensive response. Low acute risk is also a little more obvious, right? There's no presence of suicidal thoughts, no plans, no behaviors. You don't really see an indication that there's much to worry about. But that intermediate can be more challenging, right? How do you gauge those? And this tool really kind of can help you through that process. And in your sessions with the veterans you serve, you kind of want to work through that if you see any indicators of risk. Okay, so before I go on to, that's the tool in a very brief snapshot of it. Before I go on to talking about, I want to give a word to safety planning, because that's a key strategy for anyone with any level of risk of suicide, whether acute or chronic, intermediate or high. Safety planning is a great tool. So before I go into that, are there any questions? Jeff, any questions in the chat?
No, I don't see any questions in the chat right now or on Facebook. But if anybody would like to ask a question at this time, you can raise your digital hand in Zoom, and we're happy to bring you online to speak with Bradley. Okay, sounds pretty quiet. Let's keep going for now.
All right. So you've done this assessment, and let's say you've made a determination this person has some level of risk for suicide, but maybe they're not in an acute crisis. That's a great opportunity to work on safety planning. So what is a safety plan? I didn't put the reference here. It should be, again, as I mentioned, it's a tool developed by Barbara Stanley and Greg Brown out of Columbia. Safety planning really involves 6 key steps. So helping the person identify what their warning signs and triggers are. How do they know they're going into a suicidal crisis? What are the internal coping strategies they develop? Who do they know that can help distract them? What are tools they use to distract themselves when they're experiencing a crisis? Who might they reach out to in terms of their social network for help related to their crisis, right? So there are some people you may reach out to just to sort of get your mind off of things. And then there are those who you really want to talk to and you see as someone who can help you through a crisis. Do you have any professionals involved, agencies you can reach out to for support? And then finally, and very importantly, environmental safety, right? What are the access to lethal means? Do you have a gun at home? Do you have medications? What might you use to hurt yourself? Most people have a preferred method when they think about suicide. So it's important we know what those methods are that they would consider and have conversations with them about. What are the presence of those things? How do we keep you safe?
Thank you, Bradley. If I could interject for just a second, we do have a question that somebody just sent in via the chat. Margarita is wondering if these steps should be done all in one session that you've been reviewing, or is it something that would be split up over a couple of sessions?
Can I ask Margarita, the steps, are you talking about the risk assessment or the safety planning?
Margarita, do you want to unmute and speak to Bradley?
I would say like all the steps in general, like would it be done in a couple of sessions or like an intake planning?
Okay, so I'll answer actually to both. So when it comes to doing a suicide risk assessment, like with this particular tool, you know, I'm gonna assess, and you know, depending on how much I can get through, how much information, it's gonna vary veteran to veteran, you know, person to person, you know, whoever you're evaluating. And I may get enough information that I feel pretty confident I can make an assessment. But I might still feel like I need more information. So I would say in most cases, you can probably do the risk assessment in one sitting, but that may vary. Somebody may not be willing to answer questions, somebody just may not give enough information, and you may need to do it over time, or you know, my recommendation would be to complete it as best as possible. But if you feel like it needs to be reviewed or updated because you felt like you got insufficient information, then you could always do it again. Safety planning, and in my experience in doing suicide risk assessments, I anywhere from 20 to 45 minutes is what I sort of on average time have spent doing them. Safety planning is similar. The safety planning is really, I mean, both are collaborative processes, but the safety plan is the veteran's plan, right? It's the person's plan to own and utilize. So I'm going to give a little bit more leeway to them in terms of how much we're going to work on this, how many sessions it's going to take to go through each step. But overall, on average, I would think you probably are going to spend around 30 minutes. Again, some people may take longer, some shorter. One of the nice things, and I'm going to bring this up in a little bit, is that there are now mobile apps that integrate safety planning. So I often, sometimes if I'm in a virtual session or on the phone, will have the veteran pull up. The VA has an app called the Ptsd Coach. It's free, anyone can use it. And it has the safety plan we use sort of integrated into the app. And I will build it in our medical record while the veteran is doing it on their phone. And then they have it in real time and they own it in real time and can update it whenever they want. So it, again, like I would always say you leave around 30 minutes to do decent safety planning with somebody. But thank you for that question.
Yeah, and thanks, Bradley, for the answer. Also, while I'm thinking of it, is this a good time to share the link to the tool that you sent, or are you going to discuss that a little bit later?
No, you can, you can put that in the chat.
Okay, I'll drop that in there right now. Thanks.
Looks like we have a question from Skyetta Torres.
Skyetta, do you want to go ahead and ask your question to Bradley?
Okay. I don't know if you're not coming through. We're not hearing you. Okay, you're trying again. If you're having, we're still not hearing you. I don't know if you want to put your question in the chat. While
No.
oh, go ahead.
Can you hear me?
Yes.
Okay, I was gonna see if you can put the, you said you hadn't, there was an app for the VA. I'm a veteran. And so I was asking if you can put the actual tool that you were saying, I think it's the PTSD
Yes.
app that you were saying, if you can put the name in the chat for us.
I'm gonna skip ahead. I'm gonna come back to all these. These are some of the tools that I think are particularly helpful at this time, particularly around suicide prevention. The PTSD Coach, it's available for both Androids and iPhones. Thank you, Ms. Torres, for asking that question. The virtual Hope Box is actually a DoD app, but also really helpful, right? It sort of gives the veteran tools in time that they can use, right? Helps with building coping strategies, relaxation strategies, some of those distraction, whether it's games or just ways to sort of get your mind off of things, and sort of helps with positive thinking. The Mindfulness Coach is also a free mindfulness app. So if you like using some of those, more expensive apps, you can, or if you have clients who don't want to spend money on it, you can have them download the Mindfulness Coach. It's a nice tool. I actually have it on my phone and I use it periodically. And then finally, they developed the COVID Coach, which actually incorporates components of all of these things. That does not have a safety plan in it, but it does include some of the things the virtual Hope Box has, the mindfulness has, with sort of real information around COVID. And that's updated. And this is just there's the VA has created a lot of different apps, smartphone apps around mental health care, substance use care, and healthcare, physical health care that anyone can access and utilize.
Thank you. Thank you so much.
All right, so on safety planning, just to mention, safety planning is evidence-based. It has been shown to decrease suicide attempts. It's been shown to sort of decrease suicidal ideation more quickly. It's been shown to have a reduction in inpatient hospital days, increases suicide-related coping, and increases use of mental health services. Veterans in the VA have a positive response to it in evaluations that have been done within the VA system. And I think I actually find it to be really powerful, positive tool to work with somebody. If anyone has any questions moving forward, please feel free to put them in the chat or unmute yourself. I want to make sure to give you a couple of resources. So I've mentioned the Rocky Mountain MyRec a bunch of times. I highly recommend checking out their website. There's a lot of great resources there. Most of what I talked about is accessible to you there. But a resource a lot of people don't know about is that they will give you real-time case consultation. And you do not have to be employed by the VA. Your veteran, if you're treating a veteran or someone serving in the military, they don't even need to be connected to the VA. They want to be accessible to providers. Doing this work is very stressful. It can be very hard on us. And we're trying to help somebody who's maybe suicidal and we want to help them stay safe in the community. We need to make sure that we're not doing that by ourselves. So one resource for you is their consultation program. It's very easy to use. I've used it myself a few times. You get to speak with an expert that will help you think through, right, case conceptualization, risk stratification, but also things like documentation. How are you documenting your work with the veteran in a way that is informative, but also protects you? There are some clinical practice guidelines around suicide prevention to help you think through what are best strategies in suicide prevention. So that's a huge resource. One of the tools I like that they have is really, if you happen to work with someone who attempted suicide and they have family members, or you're talking to someone who has a family member who attempted suicide and there are kids in the home, this is a guide to help help the family have these conversations. Here's our contact information. So if you are working with a veteran and have any questions about how to help them, what the VA does, you can reach out to us directly. I will mention, I know there's nothing in the BRIC is one of our larger community clinics. We cover all of our community clinics. We just filled our suicide prevention case manager position there. But the suicide prevention coordinator position for BRIC is still available, and it's on USA Jobs. So I'm giving a little, promotion for that job here. It's actually really great work. I love what I do at the VA, and I love the veterans that we serve, and being able to work in suicide prevention at this time, and the VA is doing a lot of different things, is both fulfilling and exciting. I do want to mention too, that anyone who calls the Veterans Crisis Line is offered a referral by those trained responders to the suicide prevention team in New Jersey. And again, they do not have to be part of the VA healthcare system. So if you have and you know anyone who calls that line, they'll be offered the opportunity to speak to us. We will follow up the next day. And again, here's some of the resources and references. The Rocky Mountain MIREC actually has links to a series of articles on their therapeutic risk management process. So you could learn a lot more about it there. Okay. I'm just going to give a plug. Go check out this website, make the connection. These are videos of stories by veterans who have dealt with mental health recovery, substance use recovery, some stories around suicide, surviving suicide attempts. Very powerful and helpful videos. Also, the VA started a new campaign called Don't Wait, Reach Out this year. You can go to the website, learn more. If you Google it, there's a powerful public service announcement about suicide and veterans that is floating around out there, which I do recommend you take a look at when you have a chance. Okay, any other questions or thoughts?
Yeah, Jeanette had questions. I don't know, Jeanette, do you want to unmute or do you want me to just relay those? It looks like she's coming on. Hi, Jeanette. Jeanette's one of our fabulous interns.
Bradley, thank you so much for this presentation. It really touched me personally because I have relatives who are veterans. And sometimes I wish I would have learned this earlier to be able to prevent certain things. But I do have a question regarding the safety planning. I know it's more focused on the veteran. So, he's writing out what his goals are, his plans, and who's going to be supporting him. But is the family members are able to also tap into that safety plan, maybe give them, I know it's not about me, but it's about them, but just understand more of what's going on with the person.
Sure, that's a great question. Thank you, Jeanette. Yeah, the safety plan, the more that the people the veteran trusts are involved in their safety planning process, the more useful of a tool it is for them in a crisis, right? So I certainly encourage, and it is part of the conversation when we do safety planning is, who do you trust, or is there somebody who should be doing this with us, or is there someone you're going to share it with? But certainly, look, safety planning, it is a clinical tool, but it is also something that can be done by non-clinicians as well, right? So family members can work on it with the veteran, and say, hey, like, do you have one of these in place? This is really all about having this conversation around, especially if there's some acknowledgement that somebody has maybe attempted suicide in the past or struggling with depression. How do we keep you safe if and when you get to that point where you just feel like you can't take it anymore? And frankly, I find safety planning to be, it keeps the conversation focused on the reality of what the person is struggling with, but it does it in a way that is kind of generates a little bit of hope and a little bit of problem solving as well. So that's a long way of saying yes. Certainly, family members could be involved. But at the end of the day, right, like as a family member, maybe you make a suggestion, maybe you help them think of, right, like sometimes people have a hard time identifying what they do well. And I think family members are in a great position to say, hey, there have been lots of times when you've dealt with really stressful situations and you've done this, or you've done, I've seen you do these things before, or, you know, who are the friends that you're not thinking of right now that I know would be there for you? Right, so there's lots of different ways that I think family and friends could be involved in the process.
Thanks, Bradley, and thanks for the question, Jeanette. Jamila has also submitted a question. She's wondering if New Jersey uses the buddy plan to help prevent suicide among veterans.
That's a great question. So there's not in the VA system, there is not a formal like buddy program. Actually, it's interesting you bring this up. I was just talking to a colleague where we're trying to get a veteran, a peer specialist position on our suicide prevention. You know, someone who's a veteran with lived experience who can work as part of our team. It wouldn't be the same kind of a thing. However, there is a helpline, the vet to vet helpline. I don't have it in the slide deck, but it is, you know, a helpline that it's not a crisis line, but it is a helpline that a veteran can call and they will speak directly to another veteran.
We use that in one of, I did a report on it in one of my classes, and I found it rather interesting because I myself am a veteran. And so I read it and I was like, that is so helpful because we are such a close-knit community and stay in touch with each other that is very useful and helpful, because not all the time do we really want to call into the helplines and all, because I've heard veterans talk about, well, if you do that, you know, the next day or that night or whenever you hang up the phone, the police are going to be at your door. And for that, a lot of veterans are apprehensive. And then that's where we have the problems that arise.
Yeah, I think it's a great strategy. There's an organization, I have to look it up because I don't want to get their name wrong, in New Jersey that are veterans helping other veterans. So it is kind of like a buddy program, but they help in all kinds of ways. They help with someone who's experiencing a housing crisis, you know, someone who maybe needs some things, and they sort of go out there, and it's all volunteer run. And they have been involved in some of the coalitions that have been that my partners at the VA are working on to think about how they get involved around sort of helping a veteran in crisis. While we're talking, I might you know, try and find the exact name of the organization, but they're definitely worth looking at because they may do some of what you're talking about. I'm really happy to hear that we have some veterans on the call today. Thank you all for joining.
Yeah, and Bradley, if you want to look that information up and then email it to me, I can include it in the
great
email we send later today.
Great.
So we are just about out of time, and I hate to squeeze this question in at the last minute, but it is, I think, a really important thing to discuss, at least briefly. I just wanted to know if there are special considerations for working with minority population, people of color, if there are any resources along those lines available, or if there have been any studies done by the VA about special considerations in those populations.
Yeah, well, I can answer. So certainly the VA has been exploring, you know, individuals who may be more discriminated against, and the experience of that discrimination and how it contributes to their risk for suicide. In particular, the VA has put a lot of resources around the LGBTQ+ population. So LGBTQ plus veterans have dealt with challenges in their experience in the military and have brought some of that into their interactions at the VA and feelings of possibly being discriminated against. So the VA is now doing a lot to address those. They're in the process of allowing for gender affirming surgeries. We have LGBTQ plus coordinators. Every VA has one. VA New Jersey has. I actually don't have that on this slide deck, but I could send you that information. And there are some diversity and inclusion workforce groups going on at the VA as well.
Thank you so much for addressing that, Bradley. So I do want to be respectful of everybody's time, and we are at 1 o'clock. So thank you all for joining us today, and I hope you enjoyed the presentation. Thank you again, Bradley, for this great piece of information that you've shared. We will be following up with everybody who registered for this event. You'll be getting a link to the video of this presentation, which will be uploaded on YouTube, hopefully later today, as well as we'll share links again to the presentation, to the Risk ID tool, and to any other resources Bradley wants to send over to follow up with. So again, thank you all very much, and hopefully we'll see many of you at next week's community conversation. Thanks a lot, everybody. Have a great rest of your day.
Take care.